Okay, now I talked about pathophysiology, so we're going to, kind of start along that pathway. We're going to do some tools first of the posterior segment, analytical tools, and then the next hour on treatment tools, and then that'll enable us to progress on to the diseases. So we're doing the tools first. Okay, and once again, there's more. There's more. I'm not sure I could read everything that's on the pages, in the time that we have. So I'll not be reading them to you, but I'll be pointing out things as we go along. So fluorescein been around for a long time, since the 1970s. OCT is gaining increasing use. And as we'll expand a little bit later, ICG also getting increasing use as well. But this is still the gold standard, and you really need to understand it to pass the examination, because it's been around longer, more questions will be written about fluorescein than the other diagnostic aids. So it is alkaline, it has different strengths, it's very soluble, and it's cleared by the kidneys, as opposed to ICG, which you'll find, these things are all in the notes for you, but I'm giving kind of previews as we go along. ICG cleared by the bile, the liver. So in a patient with renal failure, ICG becomes a choice. Fluorescein cleared by kidneys. And first of all, in terms of the retina circulation, the retina embryologically, as you know, is part of the brain, correct? Remember the outpouching of the optic vesicle, and then the invagination of the optic vesicle, forming the neurosensory retina and the retinal pigment epithelium. But the whole outpouching was from the brain, and composed of brain tissue, so ectodermal. And the choroid and the sclera, in contrast, are mesodermal. Now, the blood vessels in the central nervous system, the brain, have a peculiar quality in that the endothelial cells have very tight junctions. And so fluorescein has a certain molecular weight, and the tight junctions in the blood vessels derived from the brain, which of course is the retina being derived from the brain, those tight junctions are not permeable to fluorescein. So in the normal state, when we inject fluorescein, it does not leak out of the normal retinal blood vessels. Are we good with that? Very basic, I'm just reviewing this very basic concept. As opposed to the choroid being not embryologically linked to the brain, being mesodermal, fluorescein freely diffuses out of the choroidal vessels, especially the choriocapillaris. Okay? So we have a situation in the eye where we inject fluorescein, and the choroid leaks fluorescein profusely. The retinal vessels leak fluorescein not at all. And the structure between the neurosensory retina, which is where the retinal blood vessels are, and the choroid is the retinal pigment epithelium. And it happens that the junction between the RPE cells is also tight and will not allow the fluorescein, which leaks out of the choriocapillaris, to diffuse into the neurosensory retina. So the fluorescein barrier that keeps it out of the neurosensory retina is twofold. Number one, the tight junctions of the retinal blood vessels, and number two, the tight junctions between the RPE cells. Are we okay with that? It's kind of a critical concept that we'll keep repeating over and over and over. Okay. A brief aside, this is a technique became in vogue in the 1970s. You're too young to know how it totally revolutionized ophthalmology. It was just such a huge explosion of knowledge that all these diseases that we talk about today were not at all understood before fluorescein came along. And the funny part of the story, it was developed in Cleveland, Ohio, a summer project for 2 medical students, okay? And they developed this technique during the summer. They approached to publish it in ophthalmology journals, and were 100% refused. Frank Newell was a very prestigious professor who at that time was the author of the principal ophthalmic textbook, The Eye, and he also refused them for publication, said it was the biggest mistake he ever made in his life. So they had to publish in a general journal called Circulation. So this technique that revolutionized our field was initially published in a non-ophthalmological journal developed by two medical students as a summer project, and neither one of the medical students went into ophthalmology. So that's a very funny story. So that's it, Novotny and Elvis. Okay. And some years ago, I wrote to this doctor, Novotny, and he works at Stanford as a child psychiatrist, and said that, you know, he had been neglected. I thought he's a very nice man. And here's a person behind that, one of the medical students who developed this technique. Okay. What is fluorescence? Briefly, it's really simple, and that's that this sodium fluorescein molecule has the capacity of absorbing incoming light, changing the wavelength, and then emitting it at back to the camera. So the light comes in. There is a excitation filter to block out all the light that's not of the proper wavelength to excite the sodium fluorescein molecule. Sodium fluorescein takes in that monochromatic light, changes the wavelength and sends it back, and there's a second filter to block out all but the wavelength of light that is generated by the sodium fluorescein. The emission filter or barrier filter takes out the reflected blue light. So it's blue light in and green light out. Very sophisticated diagram to help cement that fact away. And the Raton filters are just filters made by Kodak. They're very inexpensive, about $1 each. You can put them on your indirect ophthalmoscope, and you do fluorescein angiography if you put them on the light source of your indirect ophthalmoscope. For $1 you can do fluorescein angiography. Okay. In the bloodstream, getting on now to sodium fluorescein again, 80% of the molecules are bound, 20% are unbound. Previewing ahead with ICG is 98% binding, 2% unbound. It's the unbound fraction that gives rise to the fluorescence. So sodium fluorescein, 80% unbound. Here is our blood-retinal barrier hammering away again, the retinal component and the RPE component. To help point out the RPE component. Sorry. These are our RPE cells, and the RPE junction consists of three parts: the zonule occludens, the zonule adherens, and the desmosome. And those are three barriers to sodium fluorescein. And the combined effect of the three is that the fluorescein will stay in the choriocapillaris and not leak through the RPE into the neurosensory retina in the presence of a normal retinal pigment epithelium, just like it takes normal retinal blood vessels to maintain their impermeability to fluorescein. A safe drug. The written exam question that they tend to ask is the incidence of death, which is 1 in 200,000. Common sense things that you're probably all aware of, keeping it intravenous. Know that there's a 25% sodium fluorescein for your practice, that some people get sick with sodium fluorescein. If you lessen the amount by increasing the concentration, some of the sickness is due to a change of pH. It is alkaline. And for some people who get sick by giving them 25% fluorescein, less change of pH, less volume of fluorescein, they do well with the photography where they wouldn't if you used the normal concentration. Pregnancy and breastfeeding, never been studied, be careful. Fluorescein in the colostrum, never been studied. Patient, diabetic, whatever, that you inject the sodium fluorescein, birth defect, the mother will always think it's the fluorescein that did that. So be careful in using it in pregnancy. And with mastectomy, of course, use the other arm if you can. Also, for completeness sake, oral fluorescein, patient with no veins, whatever. Your pharmacist can get you an oral fluorescein. It does not permit rapid sequence photography, of course, but if you're looking for a late evolving condition, such as Irvine gas syndrome, aphakic CME, you can do a very creditable job by using oral fluorescein. And either camera or the $1 Ratten filter on your indirect ophthalmoscope. So for late occurring pathology, it works fine.
How long does it take to get in the bloodstream?
You can come back, it takes about an hour to show up in the eye. So into the waiting room and back in an hour. Okay, now, critical concept to walk away from for the first kind of pathophysiological pearl, the retinal barrier to fluorescein, the normal retinal blood vessels, the RPE. We'll come back to that again and again and again and again. Second, now again, trying to tie together diseases with anatomical findings. So we have to memorize a certain amount of things. Okay? What we have to memorize is that the retina has two vascular supplies. Okay? So this is our normal thickness neurosensory retina, two vascular supplies. The supply to the inner portion of the retina is supplied by the retinal vessels. The large vessels are underneath the ILM, okay? And the retinal capillaries and venules are deeper, and they supply the inner retina out to the outer plexiform layer. From the outer plexiform layer outward, including the photoreceptors, they're supplied by diffusion from the choriocapillaris. Okay? All right. And second fact we have to memorize, it's kind of intuitive, is that the optic nerve has a dual circulation. As the nerve fiber layer coalesces into the optic nerve passes through the choroid. Okay, so the optic nerve has retinal circulation from the nerve fiber layer, but also some contribution from the choroid as well. So dual circulation for the optic nerve. Okay? All right. So you're wondering, well, why is doctor bothering with these facts? What do they mean? Why is he bringing this out now? Well, for starters, let's see to emphasize with you how these things can be tied together and be helpful to you. The larger vessels are superficial underneath the internal limiting membrane. What's on the other side of the internal limiting membrane from the retina? The vitreous. So what do we get as we get older? 40% of people 40 years old, 50% of people 50 years old, clearly age-related, the onset of floaters, posterior vitreous detachment. So can we get vitreous hemorrhage and posterior vitreous detachment in the absence of a retinal tear? You're all familiar with a posterior vitreous detachment tearing the retina. Retinal tear, rhegmatogenous detachment. There might be a bridging retinal vessel that the tear has torn, producing vitreous hemorrhage. Why can we get vitreous hemorrhage in the absence of a retinal tear? Because the large retinal vessels are underneath the internal limiting membrane, and the posterior vitreous detachment tugs on the internal limiting membrane as it's detaching. So the presence of vitreous hemorrhage in posterior vitreous detachment does not necessarily mean that there will be a retinal tear. It could be due to just vitreous separation because the large retinal vessels are underneath the ILM. Good? Okay. All right, the dark appearance of the macula, the xanthophyll, the RPE cells are taller and thinner, therefore they have more melanosomes per unit area, and therefore the macula is dark because of the tall, thin RPE cells. So that's the normal dark appearance of the macula due to xanthophyll and RPE density. Okay. Common adventitial sheath surrounding AV crossings. Now that sounds kind of a silly thing. Why does doctor put that kind of stupid statement in there? What is he after? What is he trying to show me here? Okay. All right. So we're saying that the arteries cross the veins. In your experience as residents and young doctors, you all know that. The adventitial sheath wraps the two. Okay. So, okay, we went on to posterior vitreous detachment, occurs as we get older. What else occurs as we get older universally? Arteriosclerosis, right? Yeah. So arteries crossing the veins. So what happens as we get older and the arteries get hard and the arteries cross the veins and the arteries are joined to the veins by this adventitial sheath? Is it not conceivable that a hardened artery can press on a vein? especially an artery that's hardened with atherosclerosis, and therefore retinal venous obstruction, both central and branch. And the take-home fact is that this is retinal venous disease, but it's retinal venous disease caused by retinal arterial disease. That in turn brings us to our factors, our predisposing factors. And because it's arterial disease and not venous disease, it takes us away from polycythemia and hyperproteinemia, et cetera, which are very rare. And it brings us into the arterial family and brings us to hypertension. It brings us to hyperlipidemia. It brings us to rise in intraocular pressure. Higher the intraocular pressure, the harder that artery can press onto the vein. So this one little fact, the common adventitial sheath, the AV crossing, all of a sudden it's gotten us a lot of disease knowledge. We've memorized one fact and it's gotten us a cascade of conclusions that, number one, are logical, number two, they're harder to forget because they make sense, and number three, it's gotten us a huge amount of information from one fact. So that's what I'm trying to do for you with, say, pathophysiology.
Okay. So have there any studies showing that a reduction in intraocular pressure can reduce the incidence of?
It's part of the treatment. If you have a branch retinal vein occlusion and you have a glaucoma at the same time, part of the treatment would be to lower intraocular pressure. And it has been shown that there's looking at the incidence of glaucoma in the general population and the incidence of glaucoma with branch retinal vein occlusion, it's higher with those with branch retinal vein occlusion.
But I guess my thinking is that we see these older patients all the time with pressures of 17, 18, 19, and back of mine and thinking, well, if you lower this pressure, it probably could reduce the incidence of disease.
That's in patients who are normotensive, that's never been done that I'm aware of. Okay. All right. Phases of the angiogram. Unbound fluorescein molecules for the written examination, leaking out of the choriocapillaris, more permeable than the large choroidal vessels of Haller or Sattler. Okay. Patchy choroidal filling, an anatomical variant, means the choroid doesn't fill all at once. It's an anatomical variant, not a disease state, and that's what it looks like. And our phases, choroidal filling, cilioretinal artery will fill because it's choroid. Choroid fills before the retina. Arterial phase, arteriovenous and venous. Okay? That being said, it's nice to know, of course, the laminar flow indicates it's in the veins. But a bit of good news is that you needn't bother memorizing the exact vascular phase of almost any disease. It's just not important. It's important whether it's earlier or later, but the exact vascular phase is not. But in theory, you should know that it's, of course, arteriovenous and then venous. For the oral boards, that's what I'm saying. You don't get bogged down on what vascular phase it is because you're going to make a subtle mistake, and it's better to be general and correct than specific or wrong. And for the oral exam, earlier and later is as specific as you need to be. And if you're very compulsive and want to be very perfect, such as you all want to do, you can add mid if you really want to. But earlier and later is plenty more specific. Okay? All right. For the written exam, more important, you might be given a red-free. Okay, a red-free. Now, in general, the rule of thumb is if it's there for a reason. And you can get a red-free on the oral too. Okay? And it's nice to know why it's there. They're not giving it to you for nothing. It shows you better what's red, what's white, and stria of the internal limiting membrane. Another little pearl, a little bit you have to memorize, okay? But it's worth it because if you get the red free, it's going to be there for one of those three reasons. So look a little harder for diseases that either show areas of red like hemorrhage, white like hard exudates, or stria of the internal limiting membrane, otherwise known as cellophane wrinkling or epiretinal membrane. Good? So the red free tells you it's going to be one of those three. Wide field angiography. In a later lecture, next hour, we're going to be talking about OCT. You know, hang on to your hat, because OCT is showing us lots of things that most retina specialists didn't really anticipate exactly. showing us greater detail than we knew possible. And wide field fluorescein angiography is showing us the same thing. It's showing us peripheral involvement that we never suspected because our